Dr. Wadhwani received his specialty certificate in prosthodontics with a master's degree from the University of Washington School of Dentistry. He is currently in full-time private practice in Bellevue and is the past president of the Washington State Prosthodontics. He also teaches at the University of Washington in graduate prosthodontics. Both he and Dr. Pinheiro are heavily involved in prosthetic and implant research in their spare time and have authored several scientific papers, which you'll be amazed at how many, on implant restorations. So I think it's, we're going to get some more of the pearls. I'm going to have a great necklace by the time we're done. We'll charge it to Melker. And without much further ado, Dr. Wadhwani.
Thank you. So I'd like to reinforce the fact that Alfonso and I are full-time wet-fingered dentists. The information that we're going to show you, we've collected from periodontists and oral surgeons in our area and other universities. So implant cements and peri-implant disease. Is there an inconvenient truth? So the lecture's going to cover several things. As a quick outline, I'm going to introduce implants in a slightly different manner. I'm going to explain to you why some people cement, some people screw retain. I'm going to talk about teeth versus implants, what their differences are, and why perhaps implants are more vulnerable. We're going to talk about residual excess cement detection, which might be a little bit of a problem for most of us, and radiographic characteristics. We're also going to show you some clinical data. We're going to talk about osseointegration, which often comes up, and residual cement. How does the cement get down there? And then what do we know about the peri-implant disease process? Now understand, I'm using the term peri-implant disease, not peri-implantitis, because peri-implant disease is several diseases, or is a group of diseases. We're going to talk about some unique research that we believe we're the first people in the world to ever have looked at, which hopefully will make all of us think very differently about cement selection, which is microbial aspects, and then some clinical misunderstandings. And then I'm going to tell you what residual excess cement, how it affects me, the restorative dentist. The second part of this lecture is going to be Dr. Pinheiro, who will be talking about some of the solutions. So let's start with the introduction. So I believe that implants are actually highly sophisticated medical devices. In some ways, they're more sophisticated than a heart valve. And in order to attain the level of success that they can achieve, we have to treat them as sophisticated medical devices, which means that some of the things that we do on teeth are not transferable to these devices in order for them to be successful. We know with every single medical device that exists to date that there are failures. And we know that these can be attributed with implants to things such as surgical technique, patient selection, somebody who's a diabetic, somebody who's an uncontrolled diabetic or smoker, whatever, they can have a failure. Surgical technique, the better the surgeon, the higher the success rate. That's a given. And biomechanical factors can also have an effect on our patients and the implant success rates. But I'm going to focus on a subgroup where I may be involved, cementation. So let's quickly review why we cement restorations on implants. Why do we do that? Well, aesthetics. We heard that before. Aesthetics is much easier to control. You don't have a screw access hole. Also, occlusion. The best place to load an implant is down through its long axis. If you have a screw access hole there, then effectively you'll be loading air. Cost. It's generally cheaper to do a cement-retained restoration versus a screw-retained. Pacificity of fit. When you link two implants together, the superstructures that we build, some of them with porcelain, some of them with plastics, often have stresses in them. We can impart those stresses onto the implants. That could be problematic. And chair time. Generally, it's quicker to do a cement-retained restoration than a screw-retained restoration. Ask people who like screw retention, and they'll say, you know, we like screw retention because it's retrievable. The hygiene's easier to control, and the occlusal space, if we have a short occlusal height, we might have to use a screw because the retentive process of cementation may not work. In truth, the main reason why we choose this over this is familiarity. We as dentists have been taught to cement things on teeth, inlays, onlays, crowns, and bridges. As such, we are used to this technique. Rarely did we ever pick up a screwdriver at dental school for natural teeth. And this has been documented several places, that we prefer cementation because of familiarity, whereas our patients don't appear to mind which type of prosthesis they get. And this was documented by Weber. When we do talk about cementation with an implant, understand we need certain things to make the cementation process efficient. We need height. The higher the abutment, the better the cementation process. Surface area. The greater the surface area, the greater the surface area, the better the retention. And taper, just like when I prepare a tooth. If I prepare a tooth and it's very tapered, I'm more likely to lose retention through the cementation process. So taper's important, so is surface finish. The rougher the surface, the better the cementation process. And obviously the type of cement has an effect as well. And this is very similar to the natural tooth state, where retention and resistance form make a difference. But here are some differences between when we cement a crown on an implant and when we cement a crown on a natural tooth. Here's our first clinical case. This implant is placed by a periodontist. 7 months after the crown is placed, there's a sinus tract up here. The gingival tissues look really quite nice apart from this. The periodontist makes a radiograph, and there's a foreign body underneath the tissues. He raises a full thickness flap and finds there's cement under those tissues. He cleans it up, grafts it, and within a year, it's healthy again. So we started to look into the documented health around implant restorations that are either screw retained or cement retained, and we come up with several studies. These are 2 classic studies done by Weber's group. They look at implants and they follow the restorative phases after they've been restored, either screw or cement retained, and they're looking at health. They're looking at bleeding on probing depths, they're looking at color, they're looking at texture. They find after a 3 and then a 5-year period, there's a difference, with a significant difference with regard to the soft tissue around the cement-retained restorations being worse than the screw-retained restorations. And we're seeing more and more of these headliners. Cement-induced peri-implantitis, which were case reports. They were just documented case reports. We didn't have an understanding of them until 2009, when Tom Wilson comes out with this classic study. In 2009, Wilson has a cohort group of about 50 patients that have some kind of peri-implant disease. And what he does is he cleans them up, sends them away, puts them on antimicrobials, gets them back 1 month later. Then he reevaluates them. He finds the majority of them still have some irritation, so he tries to figure out what's going on. He uses an endoscope, looks underneath the tissues, and he finds in 80% of the cases, he can find residual excess cement. What he believes is happening is the bacteria are somehow seeding the cement and causing an inflammatory response. When he cleans these areas up, he finds that 3/4 of them get better, but 1/4 actively don't get better or even get worse. What's probably most interesting about his data is the time delay. The delay before anybody at all knew there was a problem. The patient didn't know there was a problem, the hygienist didn't know there was a problem, nor did the periodontist know there was a problem. And the time delay varied between 4 months and 9.3 years. He charts this, and he finds on average it takes 3 years before anybody finds the problem. Now, this is so different to traditional tooth form dentistry. When I place a crown on a natural tooth and there's an issue, my patient will almost always come back within the first few days or weeks and say, "Hey doc, there's a problem with that tooth you put on that crown." Different with implants. Something very different is going on. So here's another clinical case. Implant goes in, it's left to osseointegrate for 4 months, goes back to the restoring dentist. 3 years later, there's some inflammation around the soft tissue. The periodontist evaluates the area and pulls this tissue out. This is 3 millimeters on a perio probe. So we ask ourselves this question. We've been cementing restorations on teeth for 100 years or so, and we don't get any problems. With implants, we've traditionally been told that when you place an implant in a patient's mouth, For the first year or so, you're going to get most of your problems. Second year, you get few of your problems. And the third year, you get almost no problems, which has led us to believe that we can slap ourselves on the back, say, haven't we done a great job, go off, have a happy life. If you believe Tom Wilson's data about the 3-year effect, we may not find an issue until 3 years after restoration. And it might extend up to 9 years. And his study was only a 9-year study, so this may go out further. So if we've been doing techniques on the natural dentition for 100 years, and the periodontium around a tooth is healthy, and we do not get these issues, why would we get them if we use the same techniques on these medical devices? The first thing you have to do is look at the anatomy. So let's compare the anatomy of a tooth to an implant. So here's a tooth. You'll see the enamel, you'll see the epithelium. Look at the connective tissue attachment here. What you see is a vast array of different fibers going in different directions. They go vertically, oblique, and transverse. Some of them end up in this mineralized tissue called living cementum. They hold this complex very close to the tooth. It's taken millions of years to evolve, if you believe in evolution. If I were to cut this tooth along here and turn it towards you, these would look like spokes around a wheel, because what you actually get is compartmentalization. Compartmentalization basically prevents the spread of disease on a natural tooth. That's why you would probe maybe a 6 on the distal, a 3 on the facial, and a 2 on the mesial, because these compartments are resisting the spread of inflammation. Now look at what we see that develops in a few weeks around an implant. The first thing that you'll see is there's far fewer fibers. You'll see that they go up in an oblique or a transverse oblique position. And there's one set of fibers you do not see. They encircle the implant like a hula hoop. This attachment here is hemidesmosonal. I have a 9-year-old son. His lower canine is migrating into his mouth as it erupts. The epithelium on top of the enamel is held by a hemidesmosonal attachment. It's designed to peel away. Very different attachment system to here. The one compartment that you see is if I were to cut this across here, turn it towards you, you'd see that hula hoop. That means there's nothing to stop the progression of peri-implant disease. That's why it's 360 degrees, rather than site-specific in the case of a tooth. So we suggest in absolute health, consider the attachment of a tooth to be like a seal that's somewhat impervious to the ingress of bacteria and insult, whereas the attachment of a healthy tissue around an implant to be like a cuff, like the cuff on a ski jacket. Two very, very different situations. And what about what we do with these? When I prepare a tooth, I rarely prepare deeper than 1 millimeter below the free gingival crest, because I know I'm not going to be able to get an impression. And if there's a papilla, I bring my burr up high, and I come up above the papilla, and I stay high wherever I can. What do I ask when I ask my implant surgeon to place the head of the implant? I say, if it's a tissue-related implant, please look at the facial aspect of the gingiva and bury the head of the implant 3 millimeters below the facial gingiva. Now, these platforms are flat. Where there's a papilla, the papilla comes up. That means in this area, I'm not 3 millimeters deep, I'm 5, 6, 7 millimeters deep. Very different situation. And as I said, this relates to the tissue level type implants. Now, if I get a probe and I probe down a natural tooth and I hit 7 millimeters, what do I think? Do I like it? Of course I don't, because I know I cannot physically clean or maintain greater than 4.5 millimeters. I also know the bacteria at 7 millimeters are the type that are becoming anaerobic and the type that have the tendency to give disease. So why is it if I get a probe and I probe down by a papilla on an implant and I hit 5, 6, 7 millimeters, I think that's perfectly okay? There's a complete disconnect. And as I said, this is with the older type of tissue-related implants. Some of the companies now are telling us to place the implant level 2 millimeters below the crestal bone. This increases this dimension by 2 to 3 millimeters.